All right, guys, we're wrapping up Unit 2 with Chapter 19 and 20. So, Chapter 19 is about management of just general chest and lower respiratory tract disorders. So, yeah, that's where we'll start at. And then Chapter 20 talks all about the COPDs. Um, and so we'll get into that. So, first things first, normal x-ray. Again, don't expect you guys to be experts, but you can identify some of the areas. The one on the right kind of helps highlight stuff, so you can see the cardiac silhouette, the lungs, the individual lobes are there. They're hard to see, but AMP wise, right, the lungs on the right side have 3 lobes, and on the left side, again, patient's left, just 2 lobes. um, and you can kind of see the branches of the bronchi as they get smaller, like an upside down tree from the starting at the trachea. And so it should look pretty clear. I mean, it should be, again, like this, very like dark and full of air, that sort of stuff. You can see where the x-ray shows like this white, that's all tissue, more dense. So it should look this way. As soon as you start seeing white patches or densities on an x-ray, that's concerning. So like for this example, this is atelectasis. Um, basically the patho behind atelectasis is this is like closing or collapsing of the alveoli, causing spaces for the lungs not to fill with air. This basically overall reduces ventilation. Remember that breathing is down to VQ, ventilation kind of versus perfusion. So if my perfusion's infected, then gas exchange will be affected. If my ventilation is affected, my breathing patterns will change, and then I probably will have gas exchange issues. So this is a ventilation issue. And you can see that especially the left lower lobe is very dense and smaller in this patient. And there's some densities, opacities, whatever you want to call it, on the like right lower lobe and right mid lobe as well. So risk factors for atelectasis is foreign bodies, general altered breathing patterns. This is typically can be a secondary condition to develop. Um, Prolonged laying down, lack of ambulation, prolonged supine position, surgical procedures. So atelectasis is a very common post-op complication. This is something that's worried about in the hospital, developing from basically someone not breathing deep. And usually you'll see this after surgery post-op. So you're going to hear like decreased breath sounds. The patient may have some dyspnea, shortness of breath. Again, diminished breath sounds in the basis of the lungs. Um, the need to know here really is prevention of atelectasis is the key. If a patient is someone that is immobile and bedbound, we can frequent turns, changing positions helps, encouraging deep breathing using an incentive spirometer. You'll see a picture of it in IS later, but incentive spirometry makes people take deep breaths, initiate cough, kind of keep their lungs moving. And ambulation if they can ambulate. So cough and deep breathing, incentive spirometer, ambulation, frequent turns for those that are immobile and can't ambulate. We want to prevent anyone that's sedentary, post-op, hospitalized. You can think of atelectasis developing. And this kind of talks about some different variations of it. You're not necessarily needing to know that. Just know what atelectasis is. It's a collapsing of the alveoli causing diminished lung function. And it's a common problem in the hospital and or post-op situations. So what intervention does not help prevent atelectasis in a post-op patient? So where would you go here if you were to pick this question? It's pretty obvious because there's really only one of these that's not an intervention. It's an assessment. So that wouldn't help prevent atelectasis. That's, yeah, auscultating lung sounds doesn't do anything for us. It does help us identify atelectasis early, but doesn't help with preventing it. We need to use incentive spirometer hourly if we can get them to. Patient needs to walk. Some patients depends 2 or 3 times a day, depending on what the patient is. Assist the patient to the chair, get them up, sitting upright, change of position. And then overall pain management will help people take deep breaths if they're having pain from some kind of condition. So respiratory infections, tracheobronchitis is just a bronchial infection. slightly different pneumonia. We'll talk about pneumonia, but this is more in line with acute inflammation of the mucous membranes around the trachea and the bronchi, the large airways. This is what usually can follow an upper respiratory infection. So if I get the common cold, rhinitis, and it progresses to a lung infection, it doesn't usually go straight to pneumonia. It can, but it might go into a more tracheal bronchitis situation, and you're going to have usually a productive cough, fever, chills, some chest pain that's pleuritic, so increases with coughing, that sort of stuff. Depending on the causative agent, we could use antibiotics, but if viral, it'd have to run its course. Promote PO fluid intake, and find the causative agent and treat that is the goal for this, and management of airway patency, that sort of stuff. Pneumonia usually it can be caused by a variety of microorganisms. Can't usually this inflammation and infection happens deep in the lungs around the alveoli. So that's where pneumonia and tracheobronchitis are different. Tracheobronchitis is definitely more inflammation, infection local to the bronchi, where pneumonia is deep in the lungs at the microscopic level around the alveoli. Causes of death related to infections in the U.S. very high. Community acquired, healthcare associated pneumonia, these are big things. So community acquired pneumonia means it happens out in the community, or if someone's diagnosed with pneumonia the first 48 hours of hospitalization. This is typically all from the community. This usually comes with other predisposition. Can't talk. Comes with other predisposing factors. Some risk factors, definitely smoking, prolonged immobility for whatever reason post-surgery. Atelectasis can definitely turn into a pneumonia if an infected agent gets there and gets to growing. Swallowing issues, so dysphagia, general older age, transmission organisms by healthcare workers is where the hospital-acquired pneumonia comes from. Hospital-acquired pneumonia is considered an adverse event. That's not good, and it's going to come from something transferred around the hospital. There is a vaccine for pneumococcal. There's a couple different ones that target specific common microorganisms that cause pneumonia. And it's recommended for patients age 65 and older. I think they've even started doing it at a younger age, 40, 50 years plus. They can recommend the pneumococcal vaccine. The really best way to diagnose this is chest x-ray. Chest x-ray is the bog standard. They can do blood cultures and get a sputum sample and culture that to confirm the organism. If they're having trouble with that, if it's severe enough, they could do a bronchoscopy, a scope down the bronchial tubes and identify visually and the infection and get a sample of sputum that way. But that's a very invasive procedure. So that's kind of towards the end or very severe pneumonia. So this is showing pneumonia on a chest x-ray. You can kind of see these pockets of consolidation, these white patches where it should be kind of black and airy. It's showing areas of pneumonia, especially if this person's on the right side, which likely would probably be aspiration pneumonia, because we'll talk about aspiration, but aspiration is trouble swallowing where food or any foreign substance kind of ends up in the trachea, in the lung pathway. And if that gets down towards the bronchioles and the alveoli, this microscopic end, those are all sterile. And so if that happens, then we end up with likelihood of a pneumonia development. And it typically is the right side for aspiration dysphagia patients, because the right bronchiole is slightly larger branch, like wider and a little bit more steep, so food or foreign particles tend to end up there. So so hospital acquired pneumonia is a big deal for us in healthcare. So what's most effective in preventing hospital acquired pneumonia, especially a post-op patient? Give you a second to answer. This one's pretty easy. We already talked about it. Yeah. Incident spirometry, ambulation, encourage deep breathing, kind of preventing the development of atelectasis, which then commonly leads to pneumonia or vice versa. So Also, how does incentive thermometry device assist in preventing respiratory complications? This is pretty straightforward as well, but it's promoting deep breathing, excuse me, and preventing atelectasis. That's kind of the goal of that. So, aspiration, again, aspiration is just a general blanket term that describes anything, anytime someone swallows food or liquid or any foreign material that gets inhaled through the trachea and ends up in the lungs. This definitely is a high risk of causing pneumonia. Signs and symptoms associated with this would be like pneumonia, or you would see people, especially in the older geriatric population, you would notice someone that was aspirating if they were having coughing while they're eating, like a lot of coughing while they're eating, and they're basically kind of micro choking without really knowing it because as we get older, they're more common to suffer from dysphagia, trouble swallowing, which leads to aspiration and especially aspiration pneumonia, um, mainly because of the delayed gag reflex or diminished gag reflex. Their epiglottis, the muscular and connective tissue flap that basically closes over our trachea when we go to swallow, becomes less responsive and less flexible and tends to not always completely block the trachea, and that leads to aspiration. So, other risk factors besides age and swallowing disorders or swallowing difficulties, stroke, because it'll lead to swallowing disorders, seizures, brain injury, all these can lead to an altered level of consciousness. So, if you think patient with altered level of consciousness, inability to follow directions correctly, always giving them food is not always the best idea because we don't know how well they'll swallow. Being supine, laying flat, that sort of stuff. I mean, preventing this is when someone's eating, their head needs to be up at least 30 degrees, if not more, if they can tolerate it. Caution with eating and stuff with heavy pain meds, sedative meds. For feeding tubes, make sure there are placements in the stomach. That would prevent, and when you're doing things with someone that has a feeding tube, you can't lay them more than 30 degrees flat unless that feeding tube's held, and just be careful about that laying them flat in a bed anyway for aspiration, vomiting, and then aspirating into their lungs. And this aspiration is the reason we keep people NPO before surgery so that they don't aspirate any stomach contents they've had recently into the trachea, causing pneumonia and all kinds of issues. We could do a swallowing assessment to check for this. Think for 2 patients that are intubated, so have a breathing tube that messes with their gag reflex. So anytime someone is extubated, anytime someone has a breathing tube that's removed, swallowing needs to be assessed before we kind of say you're all clear. We need to make sure they can do that. Another big one here is TB, tuberculosis. This is a need to know. This one still comes up. It's a disease that's mostly found in places around the world that suffer from large poverty, malnutrition, overcrowding, kind of substandard housing. It's kind of like the disease of overcrowding and the poor living conditions is associated with this disease because it can spread very rapidly and very contagious, and close proximity, poor health, poor living conditions leads to that. Big symptoms, definitely cough, lots of cough, general malaise, anorexia, weight loss. The night sweats is kind of unique somewhat to TB. Afternoon low grade fever, a low grade fever that spikes just around the afternoon time, is very specific to TB. And then in later stages, you could see hemoptysis, which is bloody sputum. That's frank for tuberculous infection, and that's bad. And tuberculosis is the Mycobacterium tuberculum. It is a bacterium that's very hard to kill. It's a bacterium that can live in sputum on inanimate surfaces for days and weeks. It travels by airborne. It's airborne precautions. It's airborne transmission, so very infectious. And so for staff and the need to know for us too is that what's required for a patient is that we have to wear N95s. We're going to probably put this patient in a negative pressure room, those kind of things. Some of the meds for those, ionized rifampin, some other medications, but rifampin is one of the big drugs for this guy. and treatment takes a combination of drugs, usually 6 to 12 months plus. But it can turn your body. Rifampin is one to make a note of because it can turn body fluids orange. This is much more risky disease in immunocompromised patients, such as HIV/AIDS or other autoimmune disorders. And TB itself generally has 3 stages. There's a primary infection, initial, or you would call it initial infection. Then that usually TB can go latent or dormant. It creates little colonies basically in the alveoli, little pockets that limit alveoli function, and then can be triggered by other conditions to go back into an active state. And then that's when it would be infectious, very infectious, back to the airborne, and very risky. And it's hard to know when that transition might happen. So TB patients have to be proactive about that. There could be some chest pain with the cough as well, but mostly pleuritic. And you can see that the TB, it tends to have more upper lobe involvement versus some of the other stuff like pneumonia, atelectasis, showing on x-rays of much lower lobe involvement, that sort of thing. So that's the unique thing with TB. The other thing about diagnosing is we can do a mannitol or the PPD skin test as a transdermal injection of medication. That's goal is to trigger an antibody immune response. If the little bleb of medication kind of swells or gets red and grows in size above 5 millimeters, it's significant. We need to follow up the chest X-ray. The only definitive diagnosis, though, note this: the only definitive diagnosis of TB is through chest X-ray. The TB skin test is helpful. We use it in healthcare a lot, but it's not the gold standard. You have to still get an X-ray to confirm. And then isolation precautions. These are neat to know. You need to kind of keep these in mind. You'll definitely see some questions on NCLEX or about proper precautions, and you're definitely going to see it on this upcoming test. But airborne precautions is again highly risky. So visitors kind of need to check with nurses first. Patient is in an air isolated room or what they call a negative pressure room. Door has to be shut. Usually it has 2 doors, kind of making a security like airlock system basically. And that just kind of prevents the spread of airborne stuff into the ventilation system, stuff like that. If the patient needs to be transported anywhere, they're going to have to wear a surgical mask at minimum. Hand hygiene is always important, and then regular, PPE. For us, it's an N95 always because it's airborne with TB. Something else that would fall in this category is bacterial meningitis tends to manifest itself as an airborne spread vector. So, but yeah, that's airborne precautions. You need to have an idea of these. You need to. Other pleural conditions. So the pleura again is the double wall layer around our lungs, AMP wise. This prevents frictionless sliding movement, basically allowing. So you have the 2 layers. You have a visceral pleura that surrounds the lungs, and you have a parietal pleura that's kind of attached to the thoracic cavity, and that kind of helps the lungs expand. And they slide past each other because they have a fluid in the middle, so it's very easy. And less friction means less heat, means less damage to the tissue, and it makes our lungs expand and contract and relax more easily. If you see something called pleurisy, pleurisy is just a fancy name for inflammation of the pleura, usually both layers. And when that happens, we know that inflammation causes capillary permeability and swelling. So the pleural layers swell and they start rubbing together. And again, this is usually a secondary condition to a primary cause. You can see this in pneumonias. You can see this in upper respiratory infections that lead to tracheobronchitis. It kind of depends, but this is usually secondary to something. It doesn't necessarily just happen on its own. But the thing with pleurisy is going to be like a very sharp, kind of stabbing pain, usually unilateral. So not going to be on both sides. Usually going to be one part of the lung. And then the unique thing about pleurisy is that pain is not just kind of constant. Usually if someone was like to breathe in and hold their breath and hold their breath, the pain would kind of subside. And that's because the pleura aren't moving past each other. You're stationary with your lungs. So that's why that pain would stop when someone kind of takes a breath and holds it. These are known as kind of pleural friction rubs. Pleural, as far as their auditory, again, you can hear a pleural friction rub. It sounds like a rubbing, kind of like sandpaper, harsh sound. Again, treatment, it's treat the underlying condition. This is a secondary condition. We got to treat the primary. Pleural effusions, These are collections of fluid in that pleural space. So again, there's like 10 to 15, or maybe that's not the right amount. There's a small amount of milliliters in that fluid in between the pleura. That's just there for, again, fluid allows frictionless movement. But if fluid builds up in that space, that's called a pleural effusion. Signs and symptoms are going to depend on the size. Like, for example, in this x-ray, you can see that most of the entire left lower lobe has been compressed by fluid. This side's really bad. This x-ray is the right lung. Pretty much most of all the entire bottom two lobes and some of the upper right lobe have been suppressed down by fluid buildup. So this could very easily lead to respiratory distress or a pneumothorax, which we'll talk about in a second. But a pneumothorax is the lung collapsing on itself, and that needs to be inflated quickly. Otherwise, we're going into respiratory distress, heart organ failure, or well, more like cardiac arrest, respiratory arrest, cardiac arrest, heart will stop if a pneumothorax isn't treated. So yeah, we want to prevent this fluid buildup to the point that it's going to cause a pneumothorax. This is definitively diagnosed, auscultation. We can listen. We're going to hear diminished or absent breath sounds in these locations because the lung is compromised. But definitive diagnosis is, again, standard x-ray, and we can test the fluid. We can do a procedure called a thoracentesis. A thoracentesis is tapping into the pleural space with a needle and aspirating the fluid out. And then they'll usually send that fluid off for a sample. Pretty much if it's clear, that shows just fluid volume excess. You'd see that in heart failure patients. If it's purulent, kind of yellowy green, seems, that's infection. That's really bad. We need to figure out why that's happening. And then blood is also really bad because there's bleeding somewhere. For blood to end up in the pleural space, it's also really bad too. But I'd say the clear serous fluid is the most common. So which manifestation here is a characteristic of pleurisy, inflammation of the pleura? You answered number one, you're right. The sharp, stabbing, deep chest pain, and I would also add usually unilateral. So talking about, whoops, I kind of jumped around. Talking about pneumothorax and lung collapses, we need to talk about chest tubes. So chest tubes are, kind of skipped around, sorry. Chest tubes are drainage devices. Chest tubes have kind of a double function. If you want to think about chest tubes, their function is a drainage device. And in case of someone that has fluid buildup in the pleura, we can place a chest tube into the pleural space, pleuritic space, and drain whatever fluid is. Again, if that's blood, if that's purulent drainage, like you see on the top right here, if that's just general serous fluid, whatever it is, and we need to get it out and it help expand their lung again, we can do that. It also is for decompression, kind of keeping the negative pressure around our lungs. So we would use a chest tube with someone that has a pneumothorax, a collapsed lung, to kind of basically reinflate the lung and keep its pressure open until we can correct the reason they had a pneumothorax. And we can maintain negative pressure in the chest cavity and keep the lung expanded. So it has two purposes: drainage and keeping the negative pressure of the lung when we have a lung collapse or lung surgery. So here's a helpful video about chest tubes. I think this kind of summarizes it really well in like 6 minutes. So I'll let you guys watch this.
To prepare for chest tube insertion, get the chest tube box. Other than medications, it contains everything that the practitioner will need. Prior to insertion, set up wall section using our standard section liner and tubing. Next, we're going to prepare the chest drain. Our standard chest drain is the Atrium Oasis Dry Section Water Seal Chest Drain, as known as the Atrium 3600. It's stocked in the chest tube box. We also have the Atrium 3650, which allows for auto transfusion, and either can be ordered from SSP under chest tube drainage container. Remove the chest drain from the outer bag and perform hand hygiene. According to the manufacturer's recommendation, remove the blue wrap using sterile technique. Remove the chest drain from the box and rotate the swing out stand so it can stand on its own. Now we will fill the water seal. Remove the prepackaged 45 milliliter ampoule of sterile water from the back of the drain. Twist off the lid and squeeze the entire ampoule into the suction port located on top of the drain. This fills the water seal to the 2 centimeter line. Next, when the practitioner is ready, remove the tubing from the back of the drain You may be asked to remove the sterile cap and then hand the patient connector to the practitioner to be hooked to the thoracic catheter. When indicated by the practitioner, hook up the wall suction to the suction port of the chest drain. At the wall suction regulator, turn on suction and increase suction to at least -80 millimeters of mercury. You should see the orange suction monitor bellows expand beyond the triangle mark in the suction monitor window, indicating that suction is working. The chest drain's dry suction regulator is preset to -20 centimeters of water, although it can be adjusted from -10 to -40 using the rotary dial on the side of the drain. Do not adjust this regulator setting unless ordered by the practitioner. Remember to keep the chest drain below the level of the chest at all times. You can sit it on the floor using the swing-out floor stand, or using the multi-position hangers, you can hang it from the bed frame. Assess the dressing to make sure it is dry and occlusive. Inspect the skin for signs and symptoms of infection, and palpate the surrounding skin to identify subcutaneous emphysema. Remove any dependent loops from the tubing by looping it on the bed or chair. This allows gravity drainage and prevents pressure from building up in the pleural space. Next, assess the quantity and quality of fluid in the collection chamber. Clearly mark the level of the fluid and mark the date and time. Next, assess for an air leak by looking for bubbling in the water seal chamber. Bubbling indicates there is an air leak somewhere in the system. It could be at the patient insertion site, in the tubing or tubing connections, or a crack in the chest drain itself. The graduated markings help to quantify the size of the air leak from 1 at the lowest to 5 at the highest. Bubbling may be continuous or intermittent. If it's a new air leak, you need to identify the source of the air leak and fix it if possible. To locate the air leak, briefly clamp the chest tube at the dressing. If the bubbling stops, you know the air leak is either at the insertion site or in the lung itself. If bubbling continues, briefly clamp the tube just distal to the first tubing connection. If bubbling stops, you know the air leak is in this connection. Try to seal it by reinforcing the connection. If bubbling continues, move down the tubing and clamp about every 12 inches or so to identify the source of the air leak. If you get all the way to the drain itself and clamp and still have bubbling, you know the air leak is in the chest drain itself. You'll need to go ahead and switch out the chest drain. Keep in mind in this whole process when searching for the air leak, never clamp the tubing for more than a couple of seconds or you risk a tension pneumothorax. Next, check for titling. Titling is the up and down movement of the patient pressure float ball in the graduated water seal chamber. With inhalation, negative pressure increases and the float moves up. And with exhalation, positive pressure pushes the float back down. With positive pressure ventilation, titling will be just the opposite, and this is normal. You typically will not see titling with an air leak. Other reasons for no titling include a tubing occlusion, the lung is fully expanded, or PEEP, which can dampen oscillation. Titling is more apparent when suction is turned off. Finally, ensure that the drain's dry suction regulator is set to the right setting and that the orange suction monitor bellows is expanded to the triangle mark. If the bellows is not expanded, check that your suction tubing is connected and not obstructed. Ensure that the wall suction regulator is on and turned up enough to expand the bellows. If the order prescribes water seal, you will disconnect the wall suction from the suction port of the drain. The orange suction bellows will no longer be expanded. If the chest drain is full or has a crack in it, you will need to replace it. Make sure you have the new chest drain open and ready for connection before clamping and disconnecting the old chest drain. To switch the drains, clamp the blue patient tube clamp and disconnect the inline connector by pressing the clear button. Quickly insert the tubing into the inline connector of the new chest drain so that you hear a click indicating a good connection, and immediately unclamp the blue patient tube clamp and verify that suction is connected. If you need to collect a sample of fluid, there's a convenient sampling port here. Per policy, clean for 15 seconds. Apply a sterile syringe and get your sample. In the event the chest tube is dislodged from the patient's chest, apply a sterile occlusive dressing and tape it on 3 sides. Do not tape the 4th side to prevent increased lung tension. If a connection is dislodged at any point below the insertion site, place the end of the tubing in 1 to 2 inches of sterile water to reestablish a water seal.
So chest tubes, there's that video is helpful. There's some stuff you want to know. They can be connected via water seal, which usually means like not suction, just water sealed. This is part of the normal healing and progression. Again, need to know is if the tube becomes dislodged, you need to do a 3-sided sterile occlusive dressing. So you occlude 3 sides and leave one side open to prevent a pneumothorax. So primary chest tube management of pneumothorax. What's the primary purpose? You answered number 4, drain fluid or air from the pleural space, correct pneumothoraxes. Other conditions, pulmonary edema. This is related to fluid buildup in the lungs. MAD Dog is a nice acronym for that. With this, think airway, decrease preload or increase venous return. Other vascular disorders, pulmonary hypertension. This is usually related to right heart. Usually, this right pulmonary hypertension means high blood pressure in the pulmonary arteries around the alveoli. This typically leads to right-sided heart failure, which signs of that are the peripheral edema, fluid buildup everywhere, like the ascites, distended neck veins. We would treat that with diuretics, supplement to O2. We need anticoagulants. Try to reduce preload. Again, the load of fluid, but prior to getting to the lungs. And this is just a normal heart versus a large right ventricle, right side heart failure based on the pressure they're trying to pump against. Maybe atherosclerosis in the pulmonary arteries, that sort of thing. And again, you can kind of see the dilated heart with pulmonary hypertension. So one big thing is a need to know is PEs, pulmonary emboli or pulmonary embolism. This is a blood clot that's moved. The biggest risk factor for PEs is DVT. This is an obstruction that's a clot that's become a embolism, a thrombus that turned into an embolus by moving from somewhere, usually from a deep vein, reaches the lungs and it's too big. It gets stuck somewhere in the small arteries in the lungs. This is an occlusion. An occlusion is going to lead to this kind of dead space, which means ventilation is not happening. So because there's no perfusion, because there's no perfusion's cut off. Even if ventilation is happening, there's going to be no gas exchange. So that's PE and dead space. This can be sudden death. PEs can be sudden death, or they're going to have respiratory symptoms, dyspnea, shortness of breath. There's some lab tests that kind of help indicate this. D-dimer is a big one. D-dimer is a protein fragment created when blood clots break down. And so when we're having multiple blood clots, we'll have an elevated D-dimer. This is an image CT scan of it, or this is actually, I think, a PET scan, but it's kind of hard to tell, but you can kind of tell the branches of these arteries are blown out and full of fluid and blocked, basically. And again, the biggest thing for PEs is we got to prevent DVTs, deep vein thrombosis, blood clots that form in the deep veins. So we can do IV heparin to help with this clot, monitoring PTT and APTT. Prevention is the best form of thing. We can do blood thinners, but the best thing is prevention. Exercise, increase fluids, no smoking, weight loss, avoid crossing legs on long stationary trips like car rides, flights, moving around, that sort of thing. And ultrasounds, ambulation, those sort of things. Also, SCDs, sequential compression devices. You want to know this? Those are in the hospital. Those will compress the legs and keep the vein flow going. Okay, so pneumothorax, kind of already mentioned this, but pneumothorax is just basically a word kind of defining lung collapse. It basically means there's air or fluid in the pleural cavity that's making the lung collapse. That's all pneumothorax means. I just always associate the word pneumothorax with lung collapse. So they could have sudden pain to one unilateral pain to their lung, very sudden. It may be very limited respiratory distress or dyspnea. If the lung full collapse, so they would progress to severe distress. So air hunger, dyspnea, severe anxiety, use of accessory muscles that have central cyanosis, hypoxemia, and all the symptoms associated with that. Breath sounds may be absent in that area that's collapsed, asymmetrical chest rise. So the chest rises, like one side rises normally, the other side doesn't very well. And they could possibly have a deviated trachea. So the trachea deviates to one side or the other, and that's a compensation mechanism for the lung pressure and that sort of thing. That's a very scary sign. these are some of the types of pneumothoraxes. These are not necessarily need to know, but closed is talking about air trapping that causes the lung to collapse. Open is pneumothorax that happens from like stabbing, gunshot wound, where there's a break in the thoracic cage that air moves in. And tension could be fluid or air. So again, this is showing pneumothorax on an X-ray. Kind of see the shifting of the trachea, the shifting of all the lungs, that sort of thing. And you can see normal chest X-ray versus the pneumo. You can see the line here where that is. And so this is a video about pneumothorax. So we can watch this.
Welcome to Medics for Medics. This video will show you how to insert a chest tube for a pneumothorax. This patient has multiple rib fractures. They cause a pneumothorax with a midline shift, forming a beginning tension pneumothorax. Sterility is very important, so make sure you know and follow the standard operating procedures of your hospital. Prepare your table with sterile instruments. We'll be using a surgical clamp, scalpel, and surgical sutures. Use lidocaine 1 or 2% and determine the right chest tube size. The preferred patient position is half-seated with the arm lying aside and at shoulder level. Disinfect the thorax broadly to prevent desterilization. Before draping the patient, define intercostal level 4 to 5 to place the chest tube. Preferably use a broad sterile drape with a central opening. Anesthetize the skin covering the rib that you're using as a reference. Now anesthetize the deeper layers above the rib. Then infiltrate the intercostal muscles until you enter the thoracic cavity with a needle. Make your skin incision 2 to 4 centimeters long and parallel to the rib. Now use your surgical clamp to dissect the subcutaneous tissue. Perforate the pleural membrane using your surgical clamp. You can use your index fingers to prevent deep perforation that might damage the liver or other tissues. Now widen the intercostal wound using your index finger. Introduce the tube in the thoracic cave. You can see and hear air escaping through the tube. The tube is oriented in posterior and upward direction. Place enough sutures to prevent air suction. Use suturing wire to keep the tube into position. Keep sterility in mind when connecting the tubes, and beware to fill the drainage canister device beforehand. Start the vacuum and see how the air bubbles in your canister device. Adapt the vacuum if necessary. And finally, take a new x-ray to check for the tube position and the lung expansion. Thank you for watching this video, and please visit medicsformedics.com for more.
Okay, so that wraps up chapter 19. So next we're moving into chapter 20, COPD, and that'll be finishing off unit 2 information. So thank you guys for watching. I'll talk to you in the next one.